Good afternoon, everyone. My name is Maya Luria with TMC for Seniors. And today we're going to be doing something, we're going to be talking about men's health and about understanding our prostate. I have Dr. Lwin here with me today. It's Dr. Aye Lwin, and he spoke for us before and did such a great job. And so we have him back. And I want to just share a little bit about Dr. Lwin. He's a member of the American Urological Association and the Western section of the AUA, which is the American Urological Association, and the Arizona Urological Society. He received his medical degree from the Southern Illinois University School of Medicine, and during his residency with the University of Arizona, he received the Dr. George W. Drack Award, presented to those who exhibit extraordinary compassion in urologic care. He specializes in benign prostatic hyperplasia, which we'll be speaking about today, prostate cancer, general urology, and more. So welcome, Dr. Lwin.
Thank you.
So we have an online audience along with a small in-person audience today. I'm going to go ahead and put your PowerPoint up for you so that you can go ahead and get started. And then I'll ask you any questions that come in from our online audience.
Okay, well, thank you for the introduction. My name is Aye Lwin. I'm one of the urologists that works over at TMC, as well as I'm employed over at the Arizona Urologic, we just changed our name, Urologic Specialists, excuse me. And then just a little bit about me. I was born and raised in Illinois and did my training out here at University of Arizona. Didn't want to go back to those awful winters in Illinois, so stayed out here, okay? Today, we're going to be talking about a few different things. We'll be talking about just an overview of the prostate in terms of what does it do? Why do we need our prostates? Then we'll be specifically talking about BPH, what BPH means. And then we'll be talking then about treatment options for BPH if you think you might have it. So hopefully this is a little bit informational for you. I apologize if you were here last year and this is a little bit of a rerun. But hopefully, we'll have some good information that I did not cover last year as well. Okay. So let's talk about the prostate. So what is it? It's a little gland at the base of your bladder, about a walnut size, and it surrounds the urethra, okay? And we'll be talking a little bit more about the way, like the analogies I kind of use to make that make sense. What does it do? It produces fluid that helps transport the sperm during ejaculation. Another function it does is that it converts testosterone into a more potent form of testosterone called DHT. And I only bring that up because one of the medications for BPH that we'll be talking about a little bit later deals with that. And then so the prostate grows to a normal size in a man's early 20s, and then it starts to grow again in their about mid 40s, early 50s, and just continues to grow. And unfortunately, that will cause some problems. So what can happen? So these three different conditions all deal with the prostate. They're a little bit different. So they're related, but not always the same. Okay. So BPH is what we're going to be talking about. I'll save that for the next slide. Prostatitis is just inflammation of the prostate, meaning that, you can get infected with bacteria, especially, being close to the urinary tract. There's also like chemical irritation or inflammation of the prostate as well, just because the urine can be caustic and also cause inflammation. That does not always have to be bacterial. And then lastly, prostate cancer, one of the most common cancers in men, can also arise from the prostate. And so we'll talk more about BPH here. So BPH stands for benign prostatic hyperplasia, okay? The benign part means that it is not cancerous. Hyperplasia is a fancy word for just it growing, and then prostate obviously relating to the prostate. So, I think more commonly we just call it BPH, or an enlarged prostate is what your primary care physician might be saying, or what your urologist might be saying.
Doctor, excuse me, could you speak a little louder?
Yeah, I can speak a little louder for sure. As far as BPH goes, that prostate can get enlarged, and then it can lead to a functional obstruction of your bladder, which is called bladder outlet obstruction. And then the other subjective terms that, when your urologist or your primary care doctor is talking to you, they're called lower urinary tract symptoms. And we'll talk about those symptoms too, but what you may be experiencing when you have BPH, okay? So some things to note though, BPH is not prostate cancer. It does not cause prostate cancer either, okay? And I think the more important thing to know is that it can coexist with prostate cancer. So you may have two separate issues dealing with, the prostate, but that does not mean one leads to another. All right. They also they can have similar symptoms with each other as well to make things a little bit more confusing. Your primary care doctor may have gotten a PSA or a prostate specific antigen, and that does not talk about BPH. That is more for prostate cancer and prostate cancer screening. So let's talk a little bit about the prostate. I'd like to think of the prostate like a donut, okay? Think of the donut being the prostate. The hole, the donut hole, so to speak, is actually where you urinate from, okay? So as we get older, that donut gets larger and that hole gets smaller. And the medications that we're going to talk about here in a little bit, treatment for BPH, they're going to be affecting either the donut size or the hole size, okay? That's just how we help our patients urinate. And then another important fact to know is that prostate size does not always correlate with symptoms, meaning that, I can have patients that have, prostates with 3 times the size of a normal prostate and not have any sort of those urinary symptoms. But I could have a gentleman that, has a 1.5 times the size, or just even a normal prostate that could really be blocking him just because his donut hole is smaller. Okay. Also, you can notice here that the prostate can be part of the issue, but also anatomically, if there's like a kink or something like that, that could also lead to these lower urinary tract symptoms. I mean, it's really just all plumbing, where this bladder is a muscle and it's the pump squeezing. The prostate is like that donut, like I was telling you about, and then you have the rest of the tubing here, and that's how the urine gets out of there, okay? So what are the symptoms of BPH? I like to think of it in terms of obstructive symptoms as well as irritative symptoms. The obstructive symptoms are more of the weak stream. You have to really push to get that urine out. You don't feel like you empty your bladder. Those are like the more obstructive. Irritative symptoms could be from your prostate, or it could be from a pump issue, that bladder squeezing a lot. So urinary frequency, urgency, going at night, those are all possibilities as well. But they could also be prostatic symptoms. And then looking at the numbers, this is a very common condition, okay? Up to 95% of men with moderate symptoms are not happy. They don't want to spend the rest of their lives with these symptoms. About half of patients talk about how this interferes with their life and their lifestyle. They could have also sexual problems associated with lower urinary tract symptoms. And, this just really shows how BPH can affect man's quality of life and also the quality of their partner's lives as well. It's one of the most common problems in men above 50 years old. As we talked about, that prostate starts to grow in your 50s and just gets larger and larger. Affects half of men by age 60 and almost 90% of men by age 85. Some other, and the real only link that we've seen is that obesity and that BMI or body mass index may increase the risk of BPH. So how do we diagnose this? So the things that we can do, obviously get a history in terms of asking you guys, what kind of symptoms are you feeling? And is urination an issue? Additionally, in terms of a prostate exam, a rectal exam is a good way, or is an okay way, I guess I should say, to size the prostate. We know that, on a rectal exam, obviously not the most preferred thing in most of my patients, but we're feeling about good, the backside of your prostate. Personally, what I do in my practice, I get an ultrasound because I get a much better picture of how big the prostate is, and I can get a 3D image of it instead of just trying to figure out, extrapolate the information from just feeling like the backside of your prostate there. The PSA, like I was telling you, is a blood test. It's a screening test for prostate cancer. That could also help in diagnosing that. Some objective testing, some testing that I get numbers from. I can do something called a urinary flow test. And basically what I'm asking for you guys to do there is when you come to the clinic, I'll have you urinate into a special toilet of mine, and I can get some data in terms of how, like, the velocity at which you're urinating, and I can look at how well you're urinating just overall. And I pair that with what we call a post-void urine volume testing, which is basically an ultrasound of your bladder. After you urinate, I can see, did you empty your bladder completely, or are you so blocked up that you're not emptying your bladder? Okay. So that data kind of gives me an idea of how well you're urinating. There's also these self-evaluation of symptoms. These are just, there's a bunch of different ones. The AUA is what the American Urologic Association has out. International Prostate Symptom Score also is another one too. But basically those ones are questions that I'll be asking you in terms of the symptoms that we talked about before. Do you have a weak stream? How often is that? Do you empty your bladder? How often is that? So on and so on. How many times at night are you getting up? And there's a few other questions in there, but frequency, urgency, how much do you have to push, so on and so forth. It's a nice evaluation of how well you're doing. So moving on, we'll talk about treatment options. And the way I like to think about treatment options are basically, it is a spectrum, okay? In terms of behavioral modifications, just, the way that you can regulate fluid intake at night, changing diet, physical therapy can be part of that, versus more invasive, whether that's minimally invasive or, these days most of them are minimally invasive, or just medications. And so we'll be talking about each one of these, and there's just so many options out there these days that almost makes it a little confusing. Okay. I want to note that when you go online or to the store, they'll always try to sell you like these supplements, like to help with urination and things like that. So far, at least for the American Urologic Association, they do not recommend any particular supplement or anything, because when they look at the data, it's more of just a placebo effect, and they don't recommend any supplements to help with BPH. So the most or the least invasive thing to do is obviously just something called watchful waiting, where we just observe kind of your urination habits. This involves lifestyle modifications such as just fluid intake, medication use, and monitoring symptom progression without doing anything. Common things that I tell my patients are, to stop fluids after dinner, and that way you stop making more urine at night, if that's one of your symptoms. Urinating at night right before you go to bed twice, even if you don't feel like it, can also help, because that really empties the bladder, so you guys can actually get some sleep. If you have swelling in your legs, it's important to get the legs up earlier throughout the evening, so that you make your urine before you go to bed, because when you're laying horizontally, that's when you're going to make more urine, and then you're going to be getting up at night. Another thing that commonly gets confused with a urology issue is if you just have isolated what we call nocturia, or you're getting up just only at night. Your prostate is there 24/7. It should be affecting you throughout the day. But if it's just at night, sometimes it can be like an undiagnosed sleep apnea. Because if you have that and you're not breathing that well at night, you're going to be making more urine. There's a hormone that your body produces that can increase that urine production at night. Some side effects along for watchful waiting. It's just that, that BPH is most likely going to progress. It's not going to get any better. If it's just mildly bothering you, I think this is a good strategy to just kind of monitor. And then as you get, that's the other risks and benefits of it is I've had patients that, they just kind of keep kicking the can down the road, and they finally, get a procedure and they're like, I should have done this 10 years ago. But I mean, I tell them, look, I understand that, no, not everyone wants a procedure or start a medication or anything either. The next step, then we are starting to move into, quote unquote, doing something. So medications, that's probably the first line thing for most patients. I use a medication called tamsulosin. It falls under this category of alpha blockers. Basically what the alpha blockers do is they open up that donut hole. So when they open up that donut hole, you should theoretically be getting better urination and better flow, okay? Possible side effects, so there's tamsulosin, there's silodosin, and alfuzosin. I tend to use tamsulosin just because that has the least amount of side effects. I have had patients before that, they'll have side effects with tamsulosin, however, not with alfuzosin or something like that. So just kind of, whatever your urologist or primary care provider is prescribing you. Potential side effects, these ones will be blood pressure, so lightheadedness, dizziness, fatigue. Something that's not listed on there, that's something that can be concerning for some of my patients. This is not harmful to your body, but something called retrograde ejaculation. And that's just basically meaning that you have a dry ejaculate instead of, because that donut hole is open, your ejaculate is going to go path of least resistance, and it usually just goes back into your bladder and you urinate out that the ejaculate. So that is something that that could be considered a potential side effect. Another medication that can be used is under the drug class of 5-alpha reductase inhibitors. This is most likely going to be something called finasteride. Basically, it shrinks that prostate. It shrinks that donut, okay? It does this by stopping that, I think I was telling you, that if you remember, one of the functions of the prostate is to convert testosterone into a more potent form of testosterone called DHT. It stops that conversion and shrinks your prostate that way. It takes about 3 to 6 months to fully work when it shrinks that donut. Another use for this is if you have blood in the urine that's coming from your prostate. When your prostate gets bigger, it can sometimes bleed. This medication actually does help with blood in the urine, or something called hematuria. Potential side effects for this one include erectile dysfunction, lowered libido, ejaculatory dysfunction, breast enlargement. Personally, I don't use this medication a lot just because of the side effect profile. Also, when I was in training, I did some research on this too, and I don't want to be biased or anything, but there are some side effects that we don't still know about, where we were looking at, and these side effects did not end after stopping the drug. It kept continuing, something called post-finasteride syndrome. So personally, I just don't use this medication a lot unless my patients are not good surgical candidates. I do think that it is good for blood in the urine, so I will use it for that for those cases as well. Now we're starting to approach. So there's really only 2 medications. The third one, I will say, the American Urologic Association does state that there's a third medication that can be tried as well. It's called Cialis, or Tadalafil is the generic version. But for tadalafil, they've noticed that if you take it in a day, like a low dose every day, a daily dosing, it can also help with urination. The proposed mechanism isn't 100% understood, but the thinking is that it just opens up that donut hole again too. So something to ask your primary care doctor about or your urologist. So moving on, we're now talking more about procedures, office procedures versus procedures in the operating room. This is the next one up is something called water vapor therapy. Basically, think of me or your urologist injecting steam or water vapor into the prostate to kill off the prostate and kind of shrink the prostate over time. Okay. This can be done as an office procedure where you don't have to undergo anesthesia, or it can be done in the operating room. It's a relatively new procedure in terms of compared to a lot of the other ones. So we only have 5-year data, but our 5-year data is promising in the sense that if you look at patients having to have another treatment or have another procedure, about 4.4%. There's nothing implanted inside your body. And so I think this is a very good option. Possible side effects: blood in the urine, blood in the semen, decreased ejaculatory volume. This, as you can imagine, when you inject that steam into the prostate, that healing period, your prostate is not going to be very happy. So you can have frequency and urgency when you urinate as the prostate is healing as well. But that's just temporary, about a few weeks. I personally do this procedure. It's called Resume, but you have to have the right type of prostate configuration for this. So something if you're interested in, you have to talk to your urologist about. Prostatic urethral lift. This is also called UroLift. You may have seen this on commercials. Basically, these are permanent metallic implants that the urologist will place in the urethra, the prostatic urethra, that donut hole, and it kind of basically tacks the prostate up to the side. The way I like to think about this is like when you have on a window, like you have 2 curtains, you're kind of putting the curtains to the side to kind of open up the window. That's how I like to think of the UroLift procedure.
I don't like the side effects. Terrible.
So side effects are also similar: frequency, urgency, blood in the urine. You can have pain there as well. And then if those metallic clips ever migrate or they're not supposed to be where they are, they can cause stones when they come in contact with the urine there. When you look at, is this an office procedure? It is an office procedure as well, depending on whatever urologist you go to. The implants are permanent. And then if you look at the 5-year data through that, about a 13% chance of having to have another procedure afterwards. Okay. I will say that for both water vapor therapy and prostatic urethral lift or UroLift, if ejaculatory function is important to you, those are the only two. These are the only 2 procedures that the American Urologic Association says that will preserve ejaculatory function. Do I think that number is 0? No, but I think it's certainly less than 10%. So you're kind of boxed into both of those, or only those 2 procedures, if that is what is important for you. Next up, we have something called photoselective vaporization or laser therapy. There's a few different lasers out there and different techniques. So this is more commonly called green light therapy, but this is an outpatient procedure that uses a laser, and they aim that laser at the prostate tissue to vaporize it. Okay. This is a procedure that is done in the operating room. There's no implants or anything. If you look at the retreatment rate throughout 5 years, about 4.8%. The side effects for this one, you'll notice a theme here, but blood in the urine, urinary tract infections, pain, scarring of the urethra after surgery, and you'll notice that all the other procedures will have that dry orgasm, and it's possible to have erectile dysfunction as well. The other one, the next one we have is something called transurethral resection of the prostate, or TURP. This is, more commonly, colloquially known as like a roto-rooter. Patients, or this is again another surgical procedure that uses. There's a few ways to do this, but the most common way is to use a heated wire to physically remove tissue from the prostate. So, procedure in the operating room. There's no implants. Surgical retreatment rate. I mean, I think, to be quite honest, I think this number is probably dependent on your urologist in terms of how aggressive they are when they are resecting. But the literature states that 5.8% throughout 5 years. This procedure has been around for 50 plus years. Why? Because I believe it just works. So this is why this is one of the procedures that I perform personally, just because it works. Possible side effects are going to be, kind of the same things: urinary tract infection, frequency and urgency when you urinate, burning when you urinate, blood in the urine, dry orgasm, erectile dysfunction. And then last up, for large prostates, we have something called prostatectomy. This is a surgical removal of the inner portion of your prostate. And then this one says it's via an incision in your abdomen. So, before, I would say probably about 20 years ago, that's how these procedures were performed, by making an incision in your abdomen. This would be something called a simple prostatectomy. With advancements in robotic surgery and laparoscopic surgery, a lot of the people that do this procedure are now doing this robotically. I think that the standard for a simple prostatectomy in 2023 should probably be a robotic simple prostatectomy. Potential side effects here: bleeding, blood transfusion, although that's pretty minimal with a robotic procedure. Infection, again, scarring, urinary incontinence. These procedures are really reserved for large prostates, and so when you look at the retreatment rates, they're significantly lower, about 2.7% throughout 5 years. And of course, this will be done under anesthesia in the operating room. Another one on here, this is a little bit newer. The American Urologic Association does not have an official position on this quite yet. Some of these are still under the the research arm of urology. But basically, there's something called temporarily implanted nitinol devices, or iTind. The idea here is that they implant a nitinol device inside that donut hole, and it expands. And they leave that in for about 5 to 7 days, and they remove it. And I believe the idea is that by pushing on the of that prostate, it'll shape that prostate, and it'll kill off all the cells that are pushing on your bladder or your prostatic urethra, blocking you up, and hopefully it will give you a nice open donut hole there. These are also minimally invasive procedures. It's a temporary implant, and the data is, it's, like I said, a newer procedure, so they only have 3-year data, about 8.6% through 3 years. But yeah, you will have similar side effect profile of blood in the urine, pain, burning when you urinate, and frequency and urgency as well. Something other that's new, but the American Urologic Association does have a statement on, is something called aqua ablation. Aqua ablation, depending on your urologist, can be either an inpatient or an outpatient procedure. Basically, what they do is they use an ultrasound to visualize your prostate, and they'll look at the entirety of the donut, so to speak. And what they do is they'll using like a robotic technology, they'll look at exactly where they need to, like the limits. Maybe the donut is not a good example. Think of the prostate like an orange then. They'll look at the prostate like an orange, and they'll just use the robot to identify the fruit of the orange. And that robot will actually ablate that tissue using high pressure water, and just to remove the fruit, leaving that rind, so to speak. Okay. This is done in the operating room. There's no permanent implants, and about 5 years is about a 6% retreatment rate. Side effects are pretty similar again: blood in the urine, burning when you urinate, frequency and urgency, and then ejaculatory dysfunction. You need to also, for this one, you need to have a particular type of prostate as well, although I believe that there are some urologists that do them for all prostates. Last up, I don't even know if we need to talk about this. This is transurethral needle ablation. This is something that's been used like probably over 10 to 20 years ago. They don't even recommend it anymore, but basically it's they use 2 needles that puts in your prostate, and they kind of just cook your prostate, so to speak. American Urologic Association does not really endorse tuna anymore. And then something on here that I do something, this is probably the closest thing to prostatectomy, but it is a minimally invasive type of prostatectomy called HOLEP, or holmium laser enucleation of the prostate. It just uses a different type of laser. And think of that prostate like an orange again. I will take a laser and remove all the fruit from the rind through your urethra. So there's no cuts on your body, unlike a prostatectomy. Here in Tucson, we're fortunate because the university has, someone who trains people. So there are, multiple urologists in Tucson that perform HOLEP, where like if you go to Chicago or something like that, there's like one urologist in the entirety of the city that does that. So we're a little bit in a unique situation here. For that procedure, it's good because it's size independent, where a lot of the other procedures that I mentioned today depend on your prostate configuration. And then it's also good for patients that have larger glands, that are on like blood thinners or something like that. Side effects for that are going to be blood in the urine, something called transient incontinence, where you leak a little bit after surgery, and then the dry ejaculation as well. If you look at the data, the retreatment rate 20 years out is about 1%. So it is a very good procedure in terms of not having to have any sort of subsequent procedures. And then, a lot of my patients ask me, hey, is this covered by my insurance? Unfortunately, I don't have a good answer. It's just, you'll have to talk to your insurance provider about what prostate procedures that they do cover. And then lastly, in summary, we talked about what is the prostate, how does it work? Again, it just makes a lot of the ejaculatory fluid and converts a hormone from a more potent form of testosterone into something called DHT. And then BPH is benign prostatic hyperplasia, just meaning that large prostate, and that does not mean you have prostate cancer. And then we talked about different treatment options, include just watching and waiting, medications, office-based procedures, and then surgical procedures. All right, I think we're now going to be opening up the floor to some questions.
So thank you so much, Dr. Lwin. So I had a couple of questions. One is, what are the long-term risks for untreated BPH?
That's a great question. So long-term untreated BPH. So what happens is I'll go back to that picture. Well, actually,
I can bring it up. Hold on, I can bring it up.
Okay, cool. It's not even the greatest picture, but think of it in terms of plumbing. Okay, so what can happen to the prostate is that when you start retaining urine, that urine is going to put you at risk for hurting the bladder. Okay, so what can happen to the bladder? You can start having stones in the bladder, just because that urine will just become stagnant in the bladder, and stones can start to form there. That's number one. If you're not emptying your bladder, then that stagnant urine can also be more prone to getting infected. So you can have recurrent urinary tract infections. And then lastly, things that can be really bad are, let's say the bladder is now full. You're not getting your bladder emptied out. It can't go, you can't urinate it out. Where is it going to go? It's going to go back up into the kidneys. So it can really hurt your kidneys over time, cause them to swell. That's something called hydronephrosis, and ultimately put you in renal failure. So, I would say a majority of BPH, if it doesn't get to that degree, it's more of just a lifestyle thing. But those are the things that I've seen where, I have a patient come to clinic and they're holding on to over a liter of urine and they never even knew it, just because they got used to it.
Okay. And what about, as far as the treatments are concerned, do you tend to have to provide more than one type of treatment to find one that works? Or I know you had at the end, you sort of had your first line treatments and then sort of your surgical. What does that look like for most people? Is it
Right.
usually a one and done, or do we have to sometimes do multiple things?
It's a great question. So, the way I treat my patients, it kind of depends, right? If you're holding on to a liter of urine, you're probably going to get a more aggressive treatment. If it's just more of a lifestyle thing, then I'll just kind of ask my patients in terms of what do they want to do? Like, what is going to make you happy in the way that you urinate, and will this affect your lifestyle? And then going on to, the procedures, it's kind of it's more of a balancing act in terms of, if you want to urinate, we can get you there. That is not an issue. The other issue is there's a lot of side effects. So that means that there's risks and rewards, and we have to balance that out as, in the physician-patient relationship as well. But, for me as a surgeon, I want you to urinate, and I just want to do one procedure. I don't like my patients going under multiple procedures. So that's, to me, what would be my desire for my patients. But
I think most people don't want to have to go through more than one procedure if they don't have to either, of course. I do find it's fascinating to see how many different procedures there are, though, for BPH. I mean, really, I don't know that most other things that they get that there are that many different options.
Sure.
So trying to find the right one, I guess, right?
Right. And that's why I think, the prostate configuration is pretty important. I don't think that, I tend to joke in my clinic that every prostate is like a snowflake and everyone's a little bit different. So it's hard to just think that everything's a nail and try to hammer that. So that's why I offer about 3 different types of procedures. And I think that covers a lot of what patients' prostates could be like, as well as their desires in terms of potential side effect profiles.
So, okay, out of the 3 that you tend to use the most, can you just share on each one of those, what's the recovery period like for each type?
I mean, I'll just go through all of them. That's something that I was considering sharing, but water vapor therapy, you'll probably have a catheter for about 3 to 5 days. Those frequency urgency issues will probably, and burning when you urinate, about I would say anywhere from 2 to 4 weeks, just because your prostate is not going to be happy that we injected steam in there. Don't quote me on this, just because it's been a while since I've been doing the urolifts, but urolift, you usually have a catheter from anywhere from 1 to 7 days, depending on surgeon preference. And then you'll just have probably some pain, or at least discomfort urinating for, I would say, up to 2, maybe up to 4 weeks, but probably on the 2-week side. Green light, you'll have a catheter from anywhere from 1 to 3 days, I would say. Probably burning with urination for up to 2 weeks. TURP catheter, for most people now take the catheter out after 24 hours, with some burning with urination for about 2 weeks. The more you do in terms of removing that prostate, the advantage is that you will pay less down the road because you're physically removing tissue, if that makes sense. So for a TURP, you'll notice differences sooner because you have physically removed tissue. Prostatectomy, I don't do prostatectomy. I'll tell you about HOLEP outpatient procedure. You'll have a catheter for less than 24 hours, and probably some burning for about 2 weeks with urination, maybe some blood, and then you'll have temporary urinary leakage for up to about 3 months. ITIN, I've never done an ITIN, so I can't answer for that. And then never done aqueous ablation either, or seen it. But I hope that answers at least a lot of the different modalities of prostate treatment there.
No, that's very helpful. If somebody wanted to come see you, can you share where your office is at, and if you've got the phone number?
So if they want to see me specifically, I'm more than happy to see you guys, especially, I guess, because you guys are all from TMC. I have a subset of partners up in the Northwest office too, that they usually operate out of Northwest Hospital, if that's more convenient, if patients live in like Marana or Oro Valley or something like that here. I'm trying to find that. But yeah, my office is just on Tanca Verde. And then I also have a Safford office if I go out there.
That's great. So if somebody wants to find you, the phone number is 520-795-5830. Your office on Tanca Verde is basically at Tanca Verde and Pima area, right around there, so that they can locate you there. It's great that you have a Safford office as well. We do have folks that attend our lectures that are in Southern Arizona. So I love that you have a space down there too to see patients. I want to thank you so much for being here today and sharing all of that great information. I'm going to wrap up with our online audience, and I'll let you continue on in person. So thank you.
Thank you guys for having me. I appreciate it. And yeah, look forward to next year's talk.
Thank you. Thanks so much for being here today. We look forward to seeing you again. We will be back live on Thursday this week. That'll be Thursday, October 5th at 4 p.m. And that's for shoulder pain. Don't shrug it off, with Michael Rozelle with Tucson Orthopedic Institute. If you would like to come to that talk, please give us a call back or give us a call in the office. We'll be happy to register you. Our phone number is 520-324-1960. Thanks and have a great day.